Week 5. The theory and concepts that we will talk about this week are hospice and palliative care, death and dying, faith and spirituality, and ethics. Let's look at our objectives for this week. So the course objectives is contribute as a member of the healthcare team to healthcare activities to promote and maximize individual health and wellness. Remember, we provide that individualized care. We want to identify community resources appropriate to meet the health needs of selected individuals in a community-based setting in collaboration with the healthcare team. Just remember, there are many others on that team and all play an essential part in that patient's care. We want to think about that nursing process. We want to be able to apply critical thinking, problem-solving skills, but we want to be safe and effective while we're providing that care to our patients in whatever community setting that they're in. And we want to use our knowledge from nursing science and other fields to address health needs of individuals of various cultures and developmental stages. So we want to provide that culturally competent care. And then we want to provide that age-appropriate care. Then also we want to identify ethical, legal issues that are relevant to providing community-based care. Okay, so your weekly readings are Chapter 13, Legal and Ethical Aspects. Chapter 14, Cultural, Spiritual Aspects of Patient Care. And then Chapter 15, Loss and End of Life.
Little squeeze. You let me know when.
Yes.
A lot of times patients and families will say to me, the tone of your voice is so soothing. We trust you. And it's almost as if you were made to be a hospice nurse. And I do truly believe that this is my calling. I've been a nurse for 16 years. I've worked in assisted living, in nursing homes, correction, substance abuse, group homes, and I've been a hospice and palliative care nurse for about 2 years now. But this is the only setting that I've worked in where I've walked out of cases and say, what's my destiny? Well, not everyone can do hospice.
Hospice and palliative care and taking care of the death and dying. The nurse needs to focus on the needs of the client. We want to provide that comfortable, keeping that client comfortable and maintaining that dignity and self-esteem. Although the nurse needs to control the pain, it is not necessary to keep the client sedated so that the client is totally unaware of what is happening, just so that that patient is in less pain or as pain-free as possible. Because you want that client to be able to interact with the family members and make care decisions. Family needs are important, but the client's needs are the most important. Prescribed treatment needs to be carried out, but making the client comfortable and maintaining dignity are our priorities. In hospice and palliative care, the goal is to alleviate suffering as much as possible without attempting to cure, improving the quality of remaining life. Accepting that death is normal and expected, and humanizing that experience. Aggressive treatments most of the time are stopped, for example, chemo, dialysis, and ventilation. The goal of all interventions become focused on quality of life rather than quantity. In addition to symptom management, the patients and families receive psychological and spiritual support. Dehydration in terminally ill patients has shown in research to decrease pain and to be more comfortable, to be a more comfortable condition than when a tube feeding is introduced into the intestines, or when an IV is used to reverse dehydration. So dehydration in terminally ill patients have shown in research to decrease the pain. There's less pain when you're comparing it to adding a feeding tube or actually putting in an IV for hydration. Hospice is the palliative care of terminally ill patients and their families at home, in long-term care facilities, in small clinics also. Hospice is for the end stage of life. The primary goal of hospice and palliative care is to improve quality of life, alleviate suffering, improve end-of-life experience for the patients and their loved ones. According to the World Health Organization, the goal of palliative care is to improve the quality of life of patients and their families while dealing with a life-threatening illness by reducing and relieving the symptoms of that disease. Generally, the patient has a prognosis of no more than 6 months if all treatments were stopped. As soon as the healthcare team realizes there is no cure, the hospice discussion should be initiated. So no more than 6 months, that's that time frame. Nursing care, social support, psychological support, and spiritual support are initiated to improve the quality of life, reduce suffering, and assist in the grieving process, which starts well before death. So let's talk about physical support, social support, and spiritual support. So physical support, we want to alleviate the pain, reduce air hunger, and improve that sleep so they can get so they can be rested. Social support is looking at facilitating those relationships that may be strained or neglected that the patient wants to mend. So a lot of times they'll ask for, that child that hasn't come home in 10 years or that family member that they want to make amends with. They usually will update the will, and then they'll start saying goodbye to loved ones. That spiritual support includes finding peace with God or a higher power through a chaplain or some type of person of faith, a spiritual advisor. So know the stages of grief: denial, anger, bargaining, depression, and acceptance.
Nancy, how has mom been eating lately?
She's really lost the ability to feed herself.
Okay.
And she has good days and bad days.
When Diane comes to visit, I think it lifts up my mother's spirits. She really is very engaging with my mother. Everything okay?
Are we full of fire?
We are full of fire.
This is my mom, and this is not what you'd want to see happen to anybody. So on an emotional level, it can be hard.
When I started hospice, I had one idea of hospice. I know that hospice is a program for the terminally ill, and eventually they will die. But if you asked me to define that now, after the experiences I've had with hospice and palliative care, then I would tell anyone that it is a program that helps the terminally ill live. The good thing is that she's comfortable. She doesn't have any pain. She has a little difficulty articulating, but she seems happy.
If a family member is exhibiting that first stage of grief, denial, it is okay that the nurse just remain quiet and silent with that family member. Showing acceptance of feelings is an intervention for the acceptance or reorganization and restitution stage. Providing information needed for decision-making may be an appropriate intervention for the bargaining stage. Suggesting a referral to a mental health professional may be appropriate intervention for depression. Making decisions for the client and family removes their autonomy and decision-making from the client and the family, who are already experiencing feelings of loss of control if they cannot change the process of dying. So we want to be careful with removing that autonomy. This is an effective intervention that can further impair communication. So encouraging discussion of feelings is likely to enhance communication. The client and family need to know that someone will be supportive and non-judgmental. And, that's what we are there for. Therapeutic communication, we want to ask open-ended questions, avoid making assumptions. Do not offer platitudes or pleasantries such as everyone's dying, you're not being punished, or I'm sure God will forgive you. This is an important time of spiritual work. The patient should be allowed to pursue, communicate, and express their fears of hope and seek guidance from a spiritual advisor or a person of faith. They're becoming aware of their own beliefs and feelings about death and dying. So we should not project them on the patient or the family. We want to allow patients and their families to talk it through. Do not show discomfort, fear, or disgust in front of the family. Start with the nurse-patient relationship that is built on that mutual trust and respect. We want to offer assistance, listen, be present, offer touch if they are open to it, like a pat on the shoulder. Pain control is possible and expected. We aren't worried about addiction or dependence at this point. Opiates and non-opiates and non-pharmacologic pain management may all be used. We want to be aware of our nonverbal signs. We want to educate families on staying on top of that pain rather than letting that pain, get so bad. And then, we try to give the patient something for it because it takes a while for it to catch up. Oral pain medications is used when possible, but we also use those transdermal or rectal medications as well. As death becomes imminent, they spend more time sleeping, the appetite fades, PO intake falls, urine output decreases, incontinence may even occur. The pulse usually goes up, the blood pressure usually goes down. Skin of the extremities become mottled and cool. Respirations become shallow and irregular. You may even see those chain stokes respirations. That's where the respirations become more and more shallow, followed by those periods of apnea. Secretions pool in the lungs, causing respirations to sound moist. Unresponsive patients still hear our conversations, so be careful what we're saying. Touch and presence are comforting, even when the patient is unresponsive. Providing hospice nursing care can be mentally draining for nurses. It is important to understand our own beliefs and attitudes regarding death prior to beginning this work.
Entering a home for the first time feels strange. You don't know the patient doesn't know you, you kind of don't understand or don't know what experiences they've been through before they've gotten to you. And it's not until you develop that rapport with them and that they're trusting that they kind of let you guide them. Most patients will tell you it's the fear of unknown. I know I'm going to die. I don't know how I'm going to die. I don't know what's going to happen from here, what's going to happen to me, what's going to happen to my family after my death. We just let them know we're here on the journey. If you have symptoms, we can help you manage those. If you have familial issues, we can hold family meetings and try to address those issues. So let's continue to move on. 65. The purpose of this meeting is for all the disciplines to get together. So that's LPNs and RNs, social work, our spiritual care counselor, along with our team manager and the oversight of our team doctor. And we collaborate on each and every patient. No, she's very strongly against that.
Diane is one of our strongest nurses on the team. She's able to really understand and meet a patient where they are and meet a family member where they are, and then take it from there and really get them to, open up to her.
With hospice and palliative care, you treat the whole family. It's almost as if you become one of their family members.
Sure, I'll take a piece. Absolutely. Pat contacted me yesterday, said you were not feeling well.
A lot of abdominal pain. Yesterday was very, very nauseous.
Okay.
But now I have a sore throat. Yeah.
It's been a struggle, for 5 years now. She's throwing up, a lot of pain, a lot of discomfort. It's just like every day it's like something new. The cancer just grew so much, and it's getting harder and harder. As long as I know that she's comfortable, that I'm comfortable. And she's comfortable with Diane. She's very comfortable with Diane. I'd do anything for her. It's my girl.
It definitely is an emotional roller coaster, and we're all here for that ride. My patients, I always tell them, you are my hero, and to be there with them through all of that, and then to finally see them decline and to lose them, that is definitely the hardest part of this job. I try to help the patient understand that every day that you open your eyes is a new day to start all over. So what? There's no other treatment left, but you're not dead. There's still more life to live. You'll have good days, you'll have bad days, and it'll get to the point where you'll have more bad days than good days. And no matter what happened yesterday, how bad of a day you had yesterday, today is a new day. Cherish your days, make memories for your family members that are left behind, and enjoy the rest of the time that you have. And I'll say most of our patients do.
We want to provide that culturally competent care. And what that requires is that we have an understanding of our own culture and any biases or stereotypes that we may hold. We need to be reminded that we need to approach each client, each patient as an individual and as though that they are unique. We don't want to make any assumptions. We do not want to place our own culture above other cultures. We want to consider traditional health practices in the plan of care. Now, regarding time, cultures are considered to be either future, past, present oriented. So past oriented cultures value their ancestors in the past and can sometimes have a preoccupation with past events that make it difficult to achieve the future goals. So they are specifically focus on that past. They're not thinking about the future. They're not considering, what might happen going forward. Present-oriented cultures value the here and now, prioritizing quality of care and making decisions that make them happy right now. They're not really thinking about the past, and they're not thinking about and considering what might happen in the future. They're just thinking about that here and now. Future-oriented cultures are more likely to make sacrifices in the present in order to achieve those future or long-term goals. So we have a patient that is focused, their focus is past-oriented. They come to see you in the clinic and the doctor wants to see them back in 2 months, 6 weeks, but in the future. But we know that they are past-oriented focus. So what should we do before that patient leave that center or that clinic? Yes, we might want to go ahead and make that appointment for them because right now they are past-oriented. They're not thinking about the future, the present. So we might want to go ahead and make that appointment for them before they leave rather than saying, hey, just call us back when it gets closer to that time to make that appointment. Cultural competence requires that we approach each client as if they're unique and gather data on their beliefs and expectations. So let's think about Native Americans. They usually do not sustain eye contact in the same way as European Americans do. And the reason is because they consider it rude. So Native Americans do not usually sustain eye contact because they consider it as being rude. Jehovah's Witnesses, religion and surgery is not opposed, but the administration of blood and blood products is forbidden. Jewish clients who follow a kosher diet avoid meat from pork products, fish without scales or fins. Fruits and vegetables are considered kosher as long as there are no bugs present. Tuna, chicken, potatoes, and apples are also considered kosher and appropriate. Let's talk about the faith community nurse. The faith community nurse, or we call them also the parish nurse, is a specialized nursing practice that is more community oriented than community based. It incorporates spirituality in the community oriented nursing practice as a parish, congregation, or other faith-based community. These nurses may be volunteers, or they may be hired by that church or that religious organization. The practice is built on health education, promotion, and coordination of community resources while incorporating that spiritual health and religious practices. So an example would be, and there are so many different examples. One of the churches have this faith-based or parish nurse as part of their faith-based team. And what they do is after, the parishioners have finished with church, they bring in farmers market. They have people that bring in the farmers of the church. They bring in their fruits and vegetables and they share them with the others. They can make donations to those farmers because, the farmers, that's their job. In addition to that, the nurse may lead the exercise routine after the parishioners have finished with church services. And also they may provide that health education. So it just depends, on what that faith-based organization wants. But it's key that in every nursing practice, nurses should approach each client with an open mind and ask open-ended questions and be flexible. Religious and spiritual beliefs have a significant impact for many of our ability to cope with acute and chronic illnesses, birth of a child, death of a family member. It is important to know the difference between religion and spirituality. Religion reflects traditions or denominations. Spirituality is the individual attitudes related to a higher power and to the non-material nature of life. Many people do not have a religious tradition, but they do have spiritual beliefs that help them sustain through those hard times. So let's talk about the ethical and legal issues. What is that first step in the ethical decision-making process? What's that first step? It is to identify the ethical issues that are being faced. Then the nurse obtains relevant facts, considers appropriate approaches, makes decisions, implements the action, then evaluates the action and its outcome. The purpose of the ethics committee includes processing those ethical dilemmas, providing that education, revising policies, and also may have to create some policies and recommendations. An ethics committee would not provide care for aging clients or approve emergency mental health commitment. Moral distress is experienced when an individual is unable to act according with what one believes to be the right course of action. Moral distress is a burden for all nurses at some time or another. It can lead to burnout and leaving the profession if it's not dealt with as it comes along. Some examples of moral distress is end of life decisions, patient load too high, COVID-19 visitor restrictions, not enough ventilators, and tough decisions being made about who can get one. EMTs or emergency medical technicians being told not to bring patients to the hospital because they're unlikely to survive. Advocacy in nursing practice is the use of information and resources to benefit the client. acting in the client's best interest, we need to maintain that confidentiality, and we're acting impartially and carrying out the preferences and goals of the client with diligence and competence. If we can no longer provide high quality nursing care due to moral distress or ethical dilemmas, we must arrange for suitable alternative care before we stop caring for that client. We want to provide factual documentation. We want to ensure that our documentation contains descriptive, objective information about what the nurse sees, hears, feels, and smells. The use of inferences without supporting factual data is not acceptable because it can be misunderstood. We don't want to use vague terms. Floating is an acceptable legal practice used by hospitals to solve their understaffing problems. So your normal floor might be med-surg 3. But then if on that particular night, there's enough nurses, if the hospital deems that there are enough nurses to patient ratio, they may float you to another floor that their patient nurse ratio might not be what they deem to be safe. So floating is acceptable. Legally, the nurse cannot refuse to float unless a union contract guarantees that the nurse can only work in a specified area, or the nurse can prove a lack of knowledge for the performance of the assigned task. When faced with the situation, the nurse should identify potential areas of harm to the client.